Good afternoon, everyone. I am Catherine Brookman, Associate Director, Knowledge Transfer and Exchange, and on behalf of Dr. Jack Callahan, Director of the Center of Research Expertise for the Prevention of Musculoskeletal Disorders, or CRE-MSD as we are more commonly known, we'd like to thank you for joining us today for this free webinar, A New Way Forward for the Prevention and Management of Discomfort in Office Personnel, Learnings from Across the Globe. This is the fourth webinar in a series of 5 webinars on supporting remote office work, pivoting back to the workplace during a pandemic and the future of virtual workspaces. We'd like to acknowledge and thank our health and safety system partners who support and collaborated with us on this series, specifically today from Public Services Health and Safety Association, Patricia Clausen, Infrastructure Health and Safety Association, Peter Vai, Workplace Safety and Prevention Services, Don Patton, and Andrew Flanagan from Occupational Health Clinics of Ontario Workers. We are grateful to the Ministry of Labour, Training and Skills Development for our funding, which supports the delivery of these webinars, and of course to our presenters who provide their expertise. We ask that you keep yourself muted for the duration of the webinar as a courtesy to the presenters and all the participants. During the question and answer period, we ask that you type your questions into the chat box. The chat box can be pulled up on your screen by selecting the chat icon in the control panel that appears near the bottom of your screen. I will relay these questions to the presenter or a similar question should we have duplicate themes. Should you have a pressing question or issue such as a technology glitch that cannot wait until the end of the presentation, please type this into the chat box and we will do our best to address it right away. The format of today's webinar is as follows. The presentation will be given, after which time we will have 10 to 15 minutes for a question and answer period with our presenter. This webinar is being recorded and the recording will be made available to you on our website along with the presenter slides shortly after today's webinar. After the webinar, you will be sent a link to an evaluation. We encourage you to fill out this evaluation as it will assist us in the future delivery of our webinars. Thank you so much for joining us today, and remember to watch the CRE-MSD website and the MSD Prevention website for new resources and events. Now it is my pleasure to introduce to you our presenter today, Venerina Johnston. Venerina is joining us today from Australia. She is an honorary associate professor at the University of Queensland and director of the Good Work Lab. Venerina is a clinician with a postgraduate qualifications in occupational health and safety and work disability prevention. She has extensive industry experience and research academic experience accumulated for 30 years, working in various roles that include manufacturing, mining, local government, health and safety sectors, and workers' compensation and compulsory third-party insurers. Her research adopts a multidisciplinary approach to design and implement workplace-based interventions to reduce the overall burden of musculoskeletal disorders on the individual, employer, and society. Thank you so much for joining us today, and now over to you, Venerina.
Thank you, Catherine. So good morning, everyone. I hope you can understand my Australian accent. So it's a warm and humid morning here in Brisbane, Australia. I'd like to start this presentation by acknowledging the First Nations community who are traditional owners and their custodianship of the lands from which I present to you today, and pay my respects to their ancestors and their descendants who continue cultural and spiritual connections to country, and I recognise the valuable contributions to Australian and global society. So thank you, Jack, for the invitation to present some of my work, and a big thank you to Catherine and Bettina, who've been very supportive in making this happen. The session will include what I call a smorgasbord of studies, which will show that physical and psychosocial factors interact to increase the level of musculoskeletal pain and predict pain outcomes. And I'll be using neck pain as the example of musculoskeletal problem. I'll present evidence that the COVID lockdown didn't negatively impact musculoskeletal pain, work stress or physical activity levels in a sample of Swiss workers. And then I'll present evidence of interventions that can be implemented to prevent and reduce musculoskeletal discomfort. I've been conducting research with office personnel for about 15 years, predominantly for the prevention and management of neck pain. And the work that I'm presenting today is a summary of several studies or a smorgasbord that I or my students have been involved with. My journey in understanding the risk factors associated with musculoskeletal problems in office workers started with my PhD. And like a lot of studies at the time, it was cross-sectional. And it was investigating the relationship between various factors of neck pain and disability. I focused on neck problems because these tend to be more common among office workers. In my PhD, I administered a survey to over 300 female office workers with and without neck problems that included a comprehensive list of risk factors across the domains of the individual and workplace. At the individual level, there were measures of demographics, use of vision correction and the type of vision correction, and the psychological construct of negative affectivity. The workplace factors assessed included the demands of work, such as duration of keyboard and mouse use, duration of breaks and hours worked, but also items across the workstation, such as monitor height, distance and position, and the ability to rest forearms on the worktop. The workplace psychosocial factors assessed were based on the demand control support model by Karasak. This model proposes that high job demands, low job control, and low social support interact to create job strain that adversely affect health. So to summarise the findings, there were several factors in each of those domains associated with neck pain and disability. At the individual level, there were modifiable and non-modifiable factors such as rarely performing physical activity, a history of neck trauma, greater negative affectivity score, touch typing with extra force, and using bifocals or graduated lens. The work demands and the workstation features that were associated with neck pain were using the keyboard or mouse for more than 6 hours a day, sitting at the workstation for more than 2 hours without a break, and perceiving the workstation as very uncomfortable. Another feature was working without the arms parallel to the floor. Surprisingly, there were few factors within the workstation like the monitor height or distance or the use of armrests that were identified for the presence of neck pain. When we looked at the psychosocial factors, the only variable significantly associated with the degree of neck pain was low supervisor support. The demand control support theory indicates that these psychosocial factors and hazards interact to increase the risk of ill health. And most of the research to date has shown an association with illnesses like cardiovascular disease or gastrointestinal problems. So we went looking for these associations. So in this graph here, the y-axis, is the score on the neck disability scale, which is a 0 to 100 scale. And the higher the number, the more severe the problem. And indeed, we did find interactions between the psychosocial factors. We found that as job demands increase from low to high, high decision authority, or sometimes called job control, had an increasing effect on the degree of neck pain and disability for those experiencing low supervisor support. And this interaction is what is often termed job strain. We then went looking to see if the physical and psychosocial factors interacted to increase the risk of pain. So we can see here in this graph, so the y-axis is the same as the previous one. So it's the score on the neck disability index going from 0 to 100, but that scale is only 0 to 30. We can see that low supervisor support exacerbates the effects of using the mouse for more than 6 hours per day, while high supervisor support provides a protective function. And in this graph, we can see that low decision authority exacerbates the effects of spending more than 2 hours on computer-based tasks without a break on neck pain and disability, while high decision authority buffered this negative effect. So some key take-home messages from these series of studies is that there are many factors associated with neck problems at the individual and workplace level. Not only do psychosocial factors interact to increase the degree of neck pain and disability, but work practices interact with psychosocial factors. While these results were interesting and confirmed that physical and psychosocial factors do interact to increase the severity of musculoskeletal problems, the studies were cross-sectionals. So any relationship is association only. The other limitation in this work is that workstation features were self-report rather than objectively assessed. Then a few years ago, we were lucky enough to have a PhD student from South Korea join our team. So Dr. Yoon, pictured here, investigated the risk factors for the development of interfering neck pain in over 200 office workers. So he started with a group of office workers without neck problems, and he collected the data from two different cultures, from Brisbane in Australia and from Daegu in South Korea. In this way, we're able to identify factors at baseline that predicted the onset of a new episode of neck pain. At baseline, Dr. Yoon assessed individual, workplace ergonomic and psychosocial factors, similar to those assessed earlier, with a few exceptions. At the individual level, in addition to demographics, there were measures of psychological status, including depression, anxiety, and stress. We looked at the coping strategy that individuals use when faced with a workplace stressful situation, and we used the 26-item later coping scale, if it's something you're interested in. And that scale divides coping into two domains: control coping, so positive thinking or direct action or seeking help, and escape coping, which is about avoidance or alcohol use or other aspects of coping. Physical activity levels using the short form IPAC scale, and individual physical capacity, including neck and shoulder range of motion, strength, and endurance. The workplace ergonomic factors such as desk height, keyboard, and mouse positions were objectively assessed using a workstation observational checklist, and working posture of the head, neck, and shoulder and thorax was recorded using 3D motion sensors during 1 hour of usual work. Work practices such as total time per week, total time at the computer per day, and the duration of continuous work prior to a break were also assessed. We included measures of psychosocial factors such as job strain and social support using the job content questionnaire. The primary outcome for this particular series of studies was a new episode of interfering neck pain. Participants were asked 2 questions every month for 12 months, with interfering neck pain defined as discomfort that interfered with their daily activities and caused them to seek healthcare. What did we find? Well, the incidence of interfering neck pain observed in this study was 1.93 per 100 person months. This means there were 2 neck pain cases among 100 people every month, with the number of cases being greater in females. Interestingly, there was no difference found in the incidence between the 2 samples of Brisbane and South Korea. When considering all factors in the analysis, we found individual and workplace factors that increased the risk of neck pain. We found that increased sitting hours during the weekdays and higher levels of job strain and psychological distress were associated with an increased risk of interfering neck pain. There were non-modifiable factors such as older age and female gender also increased the risk. These factors, the factors found to decrease the risk of interfering neck pain were high levels of physical activity, greater percentage of time working in neutral head and thorax posture, greater endurance of the neck extensor muscles, and greater neck backward range of motion. As a result of this work, a simplified etiological model for interfering neck pain in office workers was developed. This model shows the individual workplace physical and psychosocial risk factors for interfering neck pain, and the factors found to have a moderating effect buffering the adverse impact. So these were control coping or high control coping, social support, and greater neck muscle endurance. So those factors are the ones in the red hexagon in the centre. What are the take-home messages from this work? Well, that individual, physical and psychosocial risk factors independently and in combination impact the development of an episode of interfering neck pain in office workers. Both physical factors such as physical activity levels, non-neutral head and thorax posture and muscle conditioning, as well as psychosocial factors such as job strain and psychological distress, potentially can protect office workers from developing interfering neck pain. There were general features such as age and gender that may threaten the office workers' neck health. Interestingly too, the results were relevant for both cultures. Therefore, when planning strategies for the prevention of interfering neck pain in office workers, we need to consider multiple individual and work-related psychosocial and physical factors, with the factors potentially modifiable and some not. So let's change direction now. Most of the studies to date where musculoskeletal problems have been conducted in the traditional office environment. Working from home is not new and has been an option since the 1970s, becoming more feasible with the growth in computer use. As a result of the COVID-19 pandemic, however, the how, where and when work is done changed rapidly in a matter of weeks. In Australia, 46% of workers were believed to be working from home. In the United States, it was 40%, and in Switzerland, the pandemic forced around 50% of employees into a working from home setting. Prior research tells us that working from home can have benefits for the employer and employee. However, at the start of the pandemic, there were concerning reports of increased musculoskeletal problems in the press and preliminary evidence of greater psychological distress. This graph here shows the preliminary results of a large study launched in Australia by researchers in Curtin University in Perth. It shows that during late April and early May 2020, well over 1/3 of all participants who were working from home most days of the week reported high or very high levels of psychological distress. And this figure is more than 3 times the amount of people experiencing such distress in Australia in 2018. Last year, I had an opportunity to be involved with researchers in Switzerland to investigate the impact of the COVID lockdown on neck pain, work stress, and physical activity in a sample of Swiss office workers. The study was nested in a longitudinal stepped wedge design, in which each participant completes a control and intervention period. The aim of the study was to test the delivery of a workplace-based exercise, health and ergonomic intervention for office workers. And the main researchers on this Swiss project are Professor Marcus Mellon and PhD student Andrea Agita. Recruitment for this randomised controlled trial commenced towards the end of 2019. Participants were office workers with and without neck pain from 2 Swiss organisations. To be eligible for this study, office workers were aged 18 to 65, working more than 25 hours a week in predominantly sedentary office work. And to investigate the impact of COVID restrictions, only those participants in the control cohort, which is similar to a waiting list, between January and April 2020, who completed all the COVID-related questions and were working from home at the time of the follow-up were included. April 2020 did coincide with week 4 or 5 of the lockdown, with the average time between the 2 time points being 101 days or 14 weeks. The measures recorded as part of the RCT were neck pain, intensity, frequency, and the degree of disability, and the measures are there on the slide. Work stress was assessed with the 50-item job stress index, and this scale indicates the ratio of work-related resources such as appreciation at work and stressors on a scale of 0 to 100. There were slight differences in the sample size for each outcome, but the sample was 70% female. There were other measures recorded as well. Of course, you've got that opportunity, so you might as well include lots of other measures. And these included physical activity using the IPAC short form, which asks about physical activity during leisure time, housework, gardening and work, and transportation within the last 7 days. And it does distinguish 3 activity types of walking, moderate intensity activity and vigorous intensity activity. The data was analysed as metabolic equivalent of task minutes per week and physical activity categories of low, moderate and high. There was a measure of self-rated quality of workstation ergonomics. So it was an overall rating. So how would you rate your workstation overall, including, the chair and the table and everything. And we used a 1 to 5 scale. So 1 was very good ergonomics and 5 was very poor. There was a measure on work practices, such as the number of breaks during work and time spent at the computer. And there was a scale on work-life balance and working times. So this was a 1 to 5 scale, so 1 being clearly better than before the pandemic and 5 being clearly worse than before the pandemic. So here are the results. There was a small reduction in the intensity of neck pain after 5 weeks of working from home, but this change was not clinically relevant. The lack of change in neck pain intensity could have been due to the low level of problems at baseline, but it's also possible that the period of time of working from home might not have been long enough to create a clinically relevant change in neck symptoms. In terms of work stress, there was no change in the work stress conditions, so the first lockdown didn't result in a difference in the sample of Swiss office workers, and it's possible that improved working times and work-life balance may have contributed to this finding, as we'll see in the next slide. The results of the other outcomes are interesting as well. There was no evidence that the number of work breaks or number of hours of computer work changed before COVID compared to afterwards. This could be considered positive given the concerns that working from home, there are difficulties with the boundaries between work and home life. There is strong evidence, I thought was interesting, that workstation ergonomics was poorer when working from home versus working in the office, but there was no association with neck pain intensity or the level of disability found. The physical activity levels during the COVID lockdown compared to before are presented here. So before the lockdown, 71% of the study participants met the recommendations for minimal physical activity. This high percentage remained unchanged during the COVID lockdown, with no change in the total physical activity in MEC minutes per week or the type of physical activity in terms of walking, moderate or physical or vigorous intensity. Across the 3 physical activity categories of high, moderate and low, 17% of participants were less active, 54% maintained their physical activity levels, and an increase was recorded in 29% of participants. So it's possible that improved work-life balance and working times may have contributed to this finding, with 43% indicating their work-life balance had improved and 38% indicating their working times were better than compared to pre-COVID. So the messages to take home from this small study was that during the first weeks of lockdown, there was no change in the intensity of neck pain or work stress or physical activity levels. And potentially it could have been due to better work-life balance. So it'd be interesting to go back and have a look at some of those measures again. Now I'll be discussing a couple of intervention studies that we've conducted at the University of Queensland. The first is investigating an exercise and ergonomic intervention, and the other is the implementation and use of sit-stand workstation. We have conducted other studies, and I've only presented these particular 2, but the other studies we've looked at include the feasibility and impact of adding exercise to using a sit-stand workstation for people who are at risk of low back pain, and another study that looks at the influence of low back pain when using a footstool in standing. So the references for those particular studies will be at the end of this presentation. So the first study that looks at a workplace-based intervention was a large prospective cluster randomised trial to test the impact of a workplace-based exercise intervention to prevent and reduce the economic and personal burden of non-specific neck pain in office personnel. We hypothesised that this intervention would reduce productivity losses in office workers with and without neck pain. It would reduce the severity of neck pain in office workers and reduce the risk of developing neck problems in office workers who are asymptomatic at baseline. We collected data at 3 time points, so baseline, 12 weeks, which was immediately after the intervention, and 12 months after the commencement of the interventions. We collected a lot of data, including individual factors of demographics, health conditions and medication use, and psychological distress levels, psychosocial factors such as personal health beliefs, and looked at demands, controls and social support, and physical activity levels. Because productivity loss was the primary outcome, the study was powered to detect a difference between groups, hence the large sample size. We recruited over 700 office workers from 14 organisations. All participants received a comprehensive assessment of their workstation, and we then randomly allocated them to receive a neck-specific exercise intervention or health education. The on-site exercise intervention consisted of a series of group-based exercises designed to strengthen the muscles of the neck and shoulder girdle. The resistance was tailored to the individual strength and capability of the person, and they were performed during work time with an exercise diary provided to record participation and as a reminder of the exercises to do. The comparator group received 12 one-hour sessions of health education. The inclusion of a health education program as an active control was to ensure both the intervention and control groups received the same attention, which was 1 hour a week, for a period of 12 weeks. But it was also included to enhance recruitment and to minimise dropouts from the control group. Information on structured physical activity guidelines or specific information on exercise were not included, with only general encouragement to stay active for better health and well-being. Attendance at these talks was recorded by the health professional delivering the talks, and you can see that some of the sessions there, the topics were practical eating, alcohol use and tobacco use, self-esteem, conflict management and resilience, and common mental health issues. The primary outcome for this study was health-related productivity loss, and this was measured with the World Health Organization's Health and Work Performance Questionnaire. This scale is a combination of absenteeism and presenteeism, and monetized productivity loss is calculated using the information provided on income. So if you're unfamiliar with the term presenteeism, it's about being at work but not performing optimally. What did we find? Well, compared to those participating in the health, education and ergonomic intervention, participants in the exercise group had lower monetized productivity loss at 12 months of 276 Australian dollars. This was primarily driven by lower presenteeism observed in the exercise group. For office workers with neck pain, the exercise intervention participants had lower absenteeism at 12 months compared to the health promotion groups by almost 1 day. So it is possible to manage productivity loss through an intervention that combines ergonomics and exercise. In terms of the impact on neck symptoms, the ergonomic and exercise intervention was more effective than the comparator in reducing neck pain intensity in all workers, so those with and without neck symptoms at baseline, and the neck cases immediately following the intervention period, but not at 12 months, with changes at 12 weeks reaching clinically meaningful thresholds. And it's possible that adherence to the intervention contributed to this finding, as it did reduce markedly, as you can see, from 70% to 21% at 12 months. We haven't published the data on the incidence of neck pain yet, but we found the 12-month incidence was 30%, with participants in the intervention group half as likely to develop neck pain as the control group, so we were quite excited by those findings. The take-home message from this particular study is that it provides evidence of possible productivity benefits in the general population of office workers and those with neck symptoms, with a combined ergonomic and exercise intervention, which can be conducted at the workplace. There was a positive impact on sickness absenteeism at work in the long term for those with neck pain, and there was a reduction in neck pain for those symptomatic at baseline, but that wasn't sustained at 12 months. And just as an interesting side finding was that the majority of the workstations assessed met the recommended guidelines. And perhaps the focus in future should be more about how people interact with their workstation and their work behaviours. So the next couple of slides are about a study that my PhD student is working on. You may recall that one of the findings of the research that Dr. Yun conducted was that longer sitting time at home and work increased the risk for neck pain, while greater physical activity decreased the risk. And these findings are somewhat consistent with those that are emerging from the literature on sedentary behaviour at work, that prolonged sitting at work is associated with an increased musculoskeletal problem, in addition to other negative health outcomes. One intervention that's becoming more visible and popular in the workplace, certainly here in Australia, is the sit-stand workstation. But there are many questions surrounding the selection and use of these workstations. So Haroon Zagoon is a PhD student at the University of Queensland and he's investigating the uptake and use of sit-stand workstations in the workplace. How organisations decide who receives these workstations and what considerations they need to take, what things they need to consider when investing in these new workstations. 2 of his studies have been published this year, so I thought I'd present some of the results. So the studies were to understand the benefits and barriers of using a sit-stand workstation from the perspective of furniture decision makers in Australia. These decision makers, of course, do vary in each organisation, and it may be a head of department, a supervisor, or the occupational health and safety officer. An online survey was administered with 270 decision makers responding. This was followed by an in-depth interview with 24 of the survey participants. Of the decision makers who completed the survey, 57% were male. 62% of participants described their role in the organisation as a team leader and included safety and health coordinators and head of departments, while the remainder were senior management, including directors, business owners and general managers. Half the organisations were public and 40% were private. The type of sit-stand workstation installed in the workplace did vary, with some indicating more than one type of workstation, but the desktop converter options and the electric sit-stand workstations were the most popular. When they were asked who had access to a sit-stand workstation, 12% reported that their organisation provided them for everyone, while most provided them on request or for those with a medical reason. Other interesting findings is that most participants reported that their organisation did not monitor the use of these workstations. About half did not provide training on the use of the sit-stand workstation, and for those respondents whose organisation did provide training programs, the training was mainly provided via person-to-person instruction occurring at the time of installation. 79% reported that their organisation didn't use any strategies to enhance the use of these workstations, and 61% indicated that their organisation did not have any policies, guidelines, recommendations, or information to support sitting less. When participants were asked about the reasons, apologies for not investing in sit-stand workstations, all commented that the financial implications of purchasing sit-stand workstations were the main reason for non-investing. The majority believed that implementing sit-stand workstations in the workplace should be for everyone, but this would involve a large expenditure for the organisation. Some decision makers were concerned about the cost benefit of investing in these workstations, expressing scepticism that all employees would actually use them regularly throughout the day or sustain their use in the longer term. Many reasons for implementing the sit-stand workstations were reported, with the most common being to reduce musculoskeletal discomfort and injuries, but also to improve health and well-being and to increase employee satisfaction. During the interviews, participants were asked to share their experiences and discuss their perceived benefits of implementing sit-stand workstations in their organisation. The feedback centred on 2 main points: the health and well-being of their employees and work outcomes such as job satisfaction and productivity. So we can see here from this quote by the OHS consultant that they did find that people who were using the sit-stand workstations liked them and they weren't getting sore backs and neck as much as they used to. And this particular safety and wellbeing advisor commented that employees felt rewarded and valued when they were provided with a sit-stand workstation. So I'll just leave that slide up for another 30 seconds to help you read the quotes. So in terms of the barriers to using a sit-stand workstation, the decision makers discussed a range of barriers, including the design limitations, which was a mismatch between the height of the person and the desk, or that the wind-up version of desks were less likely to be used than the electric height adjustable ones. The majority of decision makers reported that a lack of firm guidelines and recommendations around the use of these workstations was a significant barrier. And I'll just let you read that comment there. And you might have come across some of these comments as well in your work. There was also comments such as the individual's motivation to change was difficult, and that might impact on the use of these workstations. And that there were some practical issues that would impact on the ongoing use of these workstations, such as privacy. So the last question in the interviews with these decision makers was about future strategies that could be implemented to enhance the use and uptake of sit-stand workstations. The proposed strategies centred on 2 points: education and ongoing monitoring of the sit-stand workstations. So education of employees was considered important to raise awareness and to promote the benefits of good work practices, good posture and health benefits in general. But also we need to remove the authoritarian approach or imposing rules on the use. The language used was considered to be important, and it should encourage people to use these workstations as much as possible. Most participants highlighted that this information is best delivered through a technology-based program. So what is the take-home message from this series of studies? You're probably going, well, there's nothing new in any of that information. Well, what we can say is that half the organisations provide sit-stand workstations on request or medical reasons, and you're probably familiar with that. So I guess what raises the question that gets raised in my mind is, how does the medical practitioner or the health professional decide that a sit-stand workstation is required? The perceived benefits of sit-stand workstations seem to be universally agreed to by staff and decision makers across the world, so these findings are generalisable to a certain extent. The majority neither monitored the use of sit-stand workstations nor provide any strategies to support the use of sit-stand workstations. So that approach is somewhat inconsistent with the approach taken when implementing new equipment or processes. The finding that 50 to 60% don't provide information to support sitting less at the workplace, nor offer training to use and the use of the sit-stand workstation suggests that there's room for improvement. And it's perhaps because the decision makers themselves believe that there's a lack of resources and clear guidelines from trusted sources to guide employees through the installation of the sit-stand workstation. Have a think about what your organisation does and whether there's any opportunities to make change. So just to wrap up this presentation today, to summarise this smorgasbord of studies, I hope that the way forward is to consider risk factors across multiple domains as they interact to increase the risk for musculoskeletal problems, and we need to consider the moderating factors such as social support and coping strategies. When we're managing musculoskeletal discomfort, a combination of interventions are likely to be more helpful than single one-off interventions and not focus so much on the workstation setup. Working from home does not seem to impose a negative health impact on office workers, certainly not in the short term. And when investing in sit-stand workstations, please consider the why and how to support staff to use them. And finally, there was an international perspective to the presentation today. The data was from various cultures, including Australia, South Korea and Switzerland, which increases our confidence that the findings may translate to all office workers, regardless of where they live. And the last 2 slides include some references if you want to follow up. So that's all my presentation for now. Thank you.
Thank you so much for that very interesting presentation, Venerina, and I've been sitting all day and now I'm standing, especially after hearing your research studies. I'm going to jump right into our questions. Can you give us a little more detail about the productivity that was measured in the exercise study?
Okay, yeah, so it was self-reported productivity, so it's a 7-item scale. It's freely available from the WHO, so the World Health Organization, and there's a lot of evidence to indicate its reliability and validity, but it is self-report. It's difficult to assess what a office worker's output is, so that's why it has to be self-report. So an individual might say, so compared to everybody else in my work group, my work output is better or worse. So on a 0 to 10 scale, so that's their presenteeism. And then they also get asked about their absenteeism and to actually document the number of days or part days that they've taken off in the last 4 weeks. So there is a 4-week version as well as a 7-day version, and we use the 7-day version.
Thank you. And I haven't had a chance to look. Will you be providing a list of the resources, including the coping scale? I think you mentioned that you could.
Yeah, so because a lot of these studies were PhD studies, most of the scales used were those that were freely available, or if there's a cost associated with them, there would be minimal. So the LaTeX coping scale was a freely available scale, and I can send that to you if you can't find it.
That'd be great if you could send the link, and we'll include it when we send out the information from your webinar today.
Okay.
If exercise is a benefit in incidents of neck in the short term, do you have any thoughts on how to maintain adherence to the exercise program, or did you see anything related to how people cope to continue this?
Yeah, it's a really good question, and adherence is something that people across the globe are trying to work on improving. My colleagues in Switzerland are actually looking at using an app to support people adhere to the intervention once the intervention period has ceased. Some people use ongoing supervision and support, so having someone available to do that. Other organisations might implement having a champion, like someone within the work group who will motivate and encourage people to do some sort of physical activity. And it doesn't necessarily have to be exercise for the neck, but there are organisations that are looking at physical activity in general, and they will use a group champion. So I know that that's happening.
Thank you for that. Regarding the productivity, you reported a dollar value. Was that based on absenteeism?
No, that's the combination of absenteeism and presenteeism. So that's the
Okay.
productivity loss.
Okay, great. And I'm just going to get you to speak up a bit, only because you've just been fading in and out, and it could just be from my end, Venerina. How did you convince the organizations to allow employees to exercise during their workday?
Yeah, we've been asked that question a few times. We probably approached about 20 organisations, and not all of them agreed to participate. There were various reasons cited for not participating, things like right sizing, restructuring. We just explained to them that we had funding to do this, and it was a free intervention. Most organisations seem to understand and value the benefit of wellbeing activities in the workplace, and they saw the benefit to their employees. And generally, when they're implementing any wellbeing intervention, it does cost. But given that this was a free intervention, it was evidence-based, delivered by a university, it gave a certain amount of credibility to the intervention. So, yeah, we didn't have to work too hard. We did a presentation to the senior leadership team in each organisation, and then they made a decision as to whether they would proceed.
Can you tell us a little bit about what that exercise intervention included?
Oh, okay.
And the length.
Okay, so I'll look at the details somewhere so I can give them to you accurately.
I'm thinking about from the employer perspective, if they're thinking, well, we can integrate something for, 20 minutes, X times a week.
Yeah. So the actual intervention was 20-minute sessions, so 3 20-minute sessions a week. And they were told that at the end of the 20 minutes, if they hadn't completed their exercises, so they were given this diary and a certain number of exercises to do on each specific day. And if they hadn't completed those exercises in the 20 minutes, then they were just to drop what they were doing and go back to work. So there was a limit to the amount of time that they were exercising. We hadn't heard any concerns about not completing the exercises. So the intervention was based on previously developed intervention that was conducted in Denmark. So they'd done lots and lots of studies looking at this particular intervention, and they had really refined it to the point where, you know, there were 5 or 6 exercises and they were manageable in the time frame. So it was a 12-week intervention. There were sessions supervised by one of our research staff. So they had 1 session a week supervised by our research staff, and then they were expected to do the other 2 sessions a week independently.
Thank you. That's interesting because we have had some webinars in the past looking at exercise and the impact it has on productivity. And so I'm sure you're familiar with these type of questions. You know, how did you select the exercises? So thank you. That was helpful. Is it better for an organization to have a sit-stand workstation available to all versus medical need or upon request? And if so, what are your recommendations in how to implement or plan to evaluate the effects of the sit-stand workstations?
Oh, wow, lots of questions. Okay, so let me repeat back. So is it better for everyone to have a sit-stand workstation opposed to just for medical need?
Or is it better for the organization to have them available? So maybe not for everyone, but maybe to have them available. And if they do, you know, do you have any recommendations around how to implement and evaluate their effectiveness?
Okay, so generally the availability of sit-stand workstations should be based on need and tasks. So, for example, in the university that I work in, a lot of academics don't spend a lot of time sitting at their workstation because they're going to meetings or they're teaching or doing research. So the actual time in front of the screen is maybe a couple of hours at a time. So do they need a sit-stand workstation? Maybe not. And it does depend on the task that they're doing at the time and their overall demands of their work. Some people do find it beneficial to stand for short periods of time. There are other ways of introducing activity and movement into one's workday without having a sit-stand workstation. And I can send you a guideline and with a list of interventions and activities that people can implement at the workplace. That was done by a PhD student, but not one of mine. So
that would be excellent. Thank you.
So there's a list of strategies that can be implemented by the individual without the need for investing in a sit-stand workstation. So then the next question was, if the organisation decides that they want to implement some sit-stand workstations, how should they be implemented and how would the organisation evaluate it? I guess each organisation would need to have, or probably does have, an OHS committee and representatives, so they probably need to consult the workers to look at the implementation, and obviously it needs to take into consideration the costs for implementing. Evaluation, that's something that my PhD student is looking at the moment. So hopefully I'll have some feedback for you next year.
Thank you. We'll definitely be looking for that. And again, it could be me. I'm just going to get you to move forward when you answer.
Okay.
The effect of the exercise and the sit stand, did you see any benefit or impact on the health insurance premiums employers paid on behalf of the employees? Did it trickle down that far?
Okay, so just to clarify, in Australia, organisations and businesses don't pay health insurance for employees.
Okay.
That's something that the individual takes out. What we do have is organisations take out workers' compensation insurance for their employees, so that's mandatory. We were not privy to that information, so we don't really know. We did ask if people had submitted a claim for workers' compensation as a result of their problems. That didn't change pre and post intervention.
Okay, that's interesting. Thank you for that. And in terms of the timeline, so your research was your first study was early into COVID. Do you do you have any plans to go back and look if the results still stand or if there was a change due to the longevity of people working from home?
It's probably a question that I need to put to my colleagues in Switzerland, but certainly in Switzerland, as there is around the world, organisations are going in and out of lockdown all the time. So you would need to consider, if you're looking at the long-term impact, there will be various periods of time where they're working from home and then from the office, or what's tending to happen more now is that there's this hybrid situation where people are spending a couple of days at home and at the office as well. I'm not sure if that's happening in Canada. Is that certainly the case there?
Yes, it is. We're
Mm.
launching back into things in the last couple of months and hybrid for many office workers.
Okay.
Do you have a recommended ergonomic guideline when you're utilizing the sit-stand workstation? Is there something that you have found that's more beneficial than others?
We developed a checklist for our research, and certainly my PhD student, so Haroon, he's looking at developing an online learning module to help organisations and individuals set up their workstation and also to understand the health benefits of sitting versus standing and how to interrupt long periods of sedentary behaviour. So that's also on the cards. Sorry, I can't give you
Oh,
more
thank you.
information.
And I was just going to mention, and I see that the director of CRE-MSD has indicated that we, in fact, do have some resources on our MSD prevention guideline, including a mini poster. So encourage people to have a look at the office guideline, and it also addresses sit-stand workstations. I'm just checking to see if you have anything else to add based on these questions, Venerina, and to see if our participants have any final questions.
Fantastic questions.
Yeah,
Thank
it's
you.
a very hot topic, and we're all, I would say we're all trying different things as a result, really, of COVID and the impact it's had just on our work life.
Mm.
So very
What I've
interesting
seen
research.
What I've seen in industry here is that organisations are concerned about if people have this hybrid model of
Yeah.
working from home in the office, does the employer then have to provide or duplicate all the office support and equipment that they have in the office at the home? So, do they have to provide a computer and a sit-stand workstation and the monitors? And, do they then go out and do an assessment, and who has responsibility for that? Who carries the liability? So there's a lot of questions about, if we continue with this hybrid model, where do the responsibilities lie?
Well, we will actually have some answers
Oh,
provincially because CRE-MSD is working on looking at going back to work and the impact that the hybrid approach to office work is having. What are the supports or lack of supports, and what is preventing people from going back if in fact they don't want to go back. So we will certainly be looking at the employer's support or lack of supports for people who are uh, venturing back into the hybrid work mode, or who are now working hybrid that didn't work before. And we expect to have that survey ready by the end of this year, and then hopefully some results within the next 6 months. And maybe we'll be able to come back to you to look at some joint observations.
Oh, excellent. It's certainly a hot topic, and I know there's research groups in Australia that are looking at a similar topic.
So I'm just going to have a look here. We've just had another comment. I think it must be hard to evaluate the second point in terms of sit-stand, feeling supported when my concern is listened to by the site agreeing to a sit-stand when I ask for it. It feels bad sometimes to deny someone because they do not already have a medical reason for it. So I think people are challenged. It is still very new, this concept of sit-stand workstations. And so having a look at even what employers support it and why, and if there is actually a value, monetary, to using them would be very helpful.
Yeah, I certainly agree with that comment.
Well, I want to thank you. It is towards the end of our workday here in Ontario, and for those who have joined us. And for yourself, you are just launching into it, and we want to thank you so much. We've had very early morning rehearsals on your part, and we really appreciate the timeliness of your research and the energy that you've put into providing this webinar. So thank you very much. And I think we look forward to hearing more from you in the near future.
Thank you, Catherine, Bettina, and Jack. And thank you, participants.
Thank you. And just encourage all of our participants to join us for our last webinar on November the 30th at 10 a.m. on transitioning out of the pandemic, expected work environment, challenges and opportunities in a hybrid work era. Thank you, everyone, and have a good evening.